There is no approved drug for Sjögren's fatigue. Not one. And before we go any further, I want to be clear. That doesn't mean medications have no role in Sjögren's. Many people, myself included, take hydroxychloroquine, and some patients experience meaningful benefits from it, particularly for joint pain, inflammatory symptoms, and overall disease management. But when researchers specifically studied whether hydroxychloroquine improves the core symptoms of Sjögren's, including fatigue and dryness, the results are pretty disappointing. Other biologic therapies that generated excitement, including rituximab, infliximab, and etanercept, have also struggled to consistently improve Sjögren's and specifically fatigue in clinical trials. So if you've been told your exhaustion is simply a matter of finding the right prescription, the reality is often more complicated than that. So what are you going to do with that information? Today, I'm going to walk you through a medication called low-dose naltrexone. It is not approved for Sjögren's. I want to be very clear about that up front. This is considered an off-label use of this medication. But the mechanism is relevant, the safety profile is favorable, and if you're someone who has been through the standard options and still not getting better, this might be a conversation worth having with your clinician team. Here are 5 things you need to know, so let's get into it. Hi, my name is Dr. Kara Wada. I'm a quadruple board certified allergy, immunology, lifestyle medicine physician. I also personally live with Sjögren's disease, which means everything I'm going to tell you today, I'm thinking not just about it as your doctor, but as someone who is navigating the same treatment landscape that you are. Today's video is specifically about the use of low-dose naltrexone. What does the evidence actually say? Who is it most likely to help? And what do you need to know before you bring it up with your team of clinicians? You can save this video to review it before your next appointment. There is a lot of information here and you're going to want to be able to come back to it. Now, quick disclaimer, this is all for educational purposes. This is not individual medical advice, and I am aiming to be your favorite doctor on the internet. I am not your doctor in this context. Okay, so let's get into it. What is topic number 1? There's a treatment gap that we rarely talk about. And I want to start here because I think the context is really important. And honestly, I think most of you deserve to hear it said out loud by a physician. Fatigue affects approximately 70% of people with Sjögren's disease. It is one of the most disabling symptoms that we deal with. And as of right now, there is not a single approved therapy that targets the immune dysregulation that is often driving it. In the JOQUER trial, the largest randomized trial of hydroxychloroquine in Sjögren's, it showed improvement rates of about 17.9% with hydroxychloroquine versus 17.2% on placebo. And that was looking at improvement in symptoms of dryness, pain, and fatigue. Now, that was not considered a meaningful difference. Rituximab has also failed in randomized trials for these symptom domains. So is infliximab and so is etanercept. So what that means in practice is that most of what we're doing for Sjögren's fatigue and pain right now is pretty empiric. We're using drugs that were not necessarily designed specifically for this disease, and we're running without much trial data to support their use because the alternative is doing nothing. Low-dose naltrexone came onto my radar because of patient advocacy. A lot of you have been asking about it in the comments and Facebook communities at the summit. And when I looked at the mechanism, 5-6 years ago, and met with a pain medicine colleague that was using it in her practice, I was really intrigued. I also was nervous. It was a treatment that was new to me, and so I needed to learn and to become more comfortable with its use. So we're going to walk through in a minute kind of how it works, how we understand it to work, and why it generates so much conversation, especially in these spaces surrounding Sjögren's, mast cell activation, dysautonomia, fibromyalgia type pain, and other neuroinflammatory conditions. So what actually is LDN, or low-dose naltrexone, and how the heck does it work? All right, so we're gonna get into some science here. I'm gonna try to do my best to explain it as plainly as I can. Naltrexone at a normal dose, full dose, is typically 50 milligrams. It is an opioid antagonist or an opioid receptor blocker. It is used to help treat folks who are in recovery from opioid and alcohol dependence. That's the version you may have heard of. Low-dose naltrexone Naltrexone is a bit of a different animal. It's the same medication, but we're talking about doses more often, somewhere between 1.5 to 4.5 milligrams, but that range is actually a little bit larger in my patients. I would estimate that I have some patients on as low as about 0.5 milligrams per day. I have several patients who are on about 8 milligrams per day. But this is, roughly 1/10 to 1/20th of a standard dose. At that dose range, something interesting happens biologically. When you take a low dose of naltrexone, it briefly, temporarily blocks your opioid receptors for about 2 to 6 hours. And your body responds to that blockade by upregulating or increasing its own natural opioid production, specifically compounds called beta endorphin and something called opioid growth factor. When the drug clears your system, in that 2 to 6 hours, those natural opioids are elevated for the remaining roughly 18 hours of the day. That's the first mechanism. The second one is arguably more relevant to Sjögren's specifically. LDN also acts on something called toll-like receptor 4, TLR4. This is found on many immune cells, including microglia, which are the immune cells of the central nervous system. They are also found on mast cells. They are also found on macrophages and some other innate immune cells. When TLR4 is activated, it drives the production of inflammatory signals, including TNF-alpha and interleukin 6. LDN dampens that activation and it thereby reduces neuroinflammation. And here's why that matters for us specifically. In vitro, so in the lab, research has shown that naltrexone also inhibits interleukin 6 and TNF-alpha production following the stimulation of several other toll-like receptors, including TLR7, 8, and 9. And those can drive the interferon pathway, which is at the center of how Sjögren's causes many of our symptoms. So the mechanism is not a total stretch. This touches the same inflammatory machinery that is actually driving Sjögren's disease. All right, so why is this mechanistically relevant to Sjögren's? We're gonna get a little more serious here, stay with me. There are no clinical trials of LDN and Sjögren's disease that currently exist. So I want to be clear about that. There are some case series, but there are no situations where they've had, a group that gets LDN and a group that gets placebo and they compare the two. That would be much better evidence and data. What we currently have is mechanistic rationale. We have evidence from related conditions, and we have a few case reports, case series. So we're going to walk through the data that we do have. The strongest evidence base for the use of LDN is in folks with fibromyalgia. In a 2025 meta-analysis, it's a study of studies. They were all randomized controlled trials. It found that low-dose naltrexone was superior to placebo for fibromyalgia pain. A systematic review of 9 studies found it effective for symptomatic management with no serious adverse effects. So why does that matter for Sjögren's? Well, because Sjögren's and fibromyalgia co-occur in 15 to 31% of Sjögren's patients. There is an entity that gets discussed called central sensitization. It is where the nervous system can amplify pain signals, and it is present in about 65% of us. These patients have significantly higher pain and fatigue scores despite comparable levels of measurable disease activity. So escalating immune suppression in these patients typically doesn't help that much because the immune system may not be the primary driver of those pain and fatigue symptoms. The nervous system is also implicated in the development and propagation of these symptoms. There's also research showing that a gene called RTP4, which promotes opioid receptor expression in pain modulating pathways, is specifically upregulated in Sjögren's patients with severe fatigue. It's a direct biological link between opioid receptor biology and this fatigue pain access in our disease specifically. We also have a fair bit of research out of the multiple sclerosis community. Clinical reports document reduced fatigue and improved quality of life with the use of LDN. There's a retrospective, so a look back cohort of 128 chronic pain patients. 53.8% reported subjective symptom relief. And in a study out of Norway where patients were in a registry, they had rheumatoid arthritis, they were on LDN. Those who continued using it persistently showed a 23% reduction in the amount of pain medicine they needed. Now, this is not proof that LDN works for Sjögren's. It's mechanistic and analogous evidence in similar conditions that makes it a reasonable conversation to have. So who might be most likely to benefit? We're gonna fly through this because I know you're busy, but this section matters because not everyone with Sjögren's is an equal candidate for this conversation. Recent cluster analyses have identified distinct subgroups within Sjögren's disease. So Sjögren's disease is this overall umbrella term, and there are subgroups or smaller groups within that overarching disease. Of those subgroups, there is a group called the low systemic activity, high symptom burden phenotype. This group of folks has prominent fatigue, pain, and dryness, but they have relatively low scores on other standard disease activity measures that are used. And these patients are unlikely to respond to B-cell targeting biologics or immune suppressants because the active systemic inflammation is not primarily driving their symptoms. LDN's mechanism, which is modulating neuroinflammation and opioid tone rather than suppressing adaptive immunity, may be a better fit for this group. The patients I'd be most interested in having this conversation with are those who've had all four of the following: predominantly fatigue and widespread pain with this low disease activity scores, those who have features that are very similar or suggestive of fibromyalgia or central sensitization like picture, those with neuropathic symptoms that might suggest small fiber neuropathy, and those who've had an inadequate response to hydroxychloroquine and other standard symptomatic therapies. Now, on the other hand, if someone has high systemic disease activity, active organ involvement like interstitial lung disease, vasculitis, cryoglobulinemia, kidney disease, liver disease, right? This is not the conversation that I would prioritize with them if I were seeing them in my clinic. We would be talking about targeted immune suppression and leaving this symptom modulating agent a little bit on the back burner until we use the fire extinguishers to put the raging inflammatory fire out. There's one absolute contraindication that I have to name clearly. If someone is currently using any opioid containing medication, LDN is not typically an option because it will precipitate withdrawal symptoms. And this is not a minor caution, it's a pretty hard stop. So that is, again, something to talk about. If you do need to use opioid containing pain medications on a regular basis, then LDN is probably not a good fit at that time, place, and space. All right, so number 5, what do you need to know and what do you think about and ask your doctor about? So let's talk about what actually happens when you want to try to access use of this medication, because there are some practical realities worth knowing before you walk into that appointment. First, LDN or low dose naltrexone is not commercially manufactured at the doses used for this neuroinflammatory treatment approach. The lowest commercially available naltrexone tablet is 50 milligrams, and we're talking about using 1.5 to 4.5, somewhere in that ballpark. So often it will be prescribed to a compounding pharmacy. That means your prescription would be sent to a specific pharmacy that is a compounding pharmacy that essentially creates customized tablets or capsules or a liquid specifically for you. Not everyone and not every area has easy access to one, which is worth knowing up front. Alternatively, the 50 milligram tablets are able to be dissolved in water, and there are protocols that are published in reputable journals on how to compound this medication into a liquid at home. This is often what I talk about doing with many of my patients. I am a Midwest mom at heart. I love a good deal. And those tablets are approximately $1 each. If a 50 milligram tablet can last you 10 days, then a month's worth of treatment is typically less than $5. And so that is a pretty cost-effective option for folks. Now, the drawback is that that liquid solution tastes like crushed pill, so it's not flavored great. And if you're someone who travels a fair bit, it can be a little cumbersome because it is a liquid solution, so you got to deal with TSA and all of that. The other issue that comes up is most insurance companies will not cover compounded LDN because it is used off-label, and just generally they don't tend to cover compounded medications. The out-of-pocket cost is typically around $30 to $60 per month when it's ordered from compounding pharmacies. So that's something to be aware of. The third issue is that many clinicians are still quite hesitant to prescribe it. Not necessarily because it's dangerous, although there may be some misperceptions and kind of misunderstandings of that. But there are large randomized trials and meta-analyses that have looked at safety. Naltrexone's patent expired shortly after I was born, 1985. So unfortunately, there are no pharmaceutical companies that are funding trials for generic or for kind of these lower dose strategies. And that absence of industry funding has created a gap in the evidence base that makes prescribers cautious, even when the safety profile is actually quite good. So on safety, LDN is generally well tolerated. The most commonly reported side effects are vivid dreams. Very rarely, I've had some patients express that they have had some nightmares, but that's less common. Headaches, nausea, some initial fatigue or irritability. Most of this is mild and often transient. There have been no serious adverse effects or events that have been reported in the studies that have been published. The concerning side effects associated with full dose naltrexone are rare, but there have been, and this is with 50 milligrams doses and higher, there have been some rare reports of liver toxicity, some issues with depression and other related downstream effects. None of these have been reported at the low doses. I have had a few patients who've had some changes in mood that we've had to kind of walk through and deal with, and certainly this medication generally is well tolerated. I also care for a group of patients who are just generally much more sensitive to medications. And so I absolutely have had some folks where this just wasn't a great fit for them. Or I've had some folks who've been on it for 3 to 6 months and said, gosh, I don't notice much of a difference. So I don't really feel like I want to stay on it. Which this goes back to just realizing that even if we have a group of people with the exact same diagnoses on their list, that they may respond differently to different treatment approaches. If you are someone who's already on hydroxychloroquine or methotrexate, there aren't any specific interactions over and beyond what normal monitoring would and should look like for those other medications. And typically the starting dose often discussed is starting somewhere around 1 to 1.5 milligrams. I tend to start folks even lower. Again, I have a special group of folks I care for, so I typically will start at about 0.5 milligrams, and they can be taken in the morning or the bedtime, depending on how each person responds. I will say when I took my first dose, I was wide awake 2 hours later. So for me, I have to take it earlier in the day. For those who, some folks will find it makes them a little more sleepy. And so taking it in the bedtime or evening would be better timing for them. Response timelines from the fibromyalgia literature range from 4 to 12 weeks. So this typically does require the good college try of a good 3 months, like many of our disease modifying type medications that are used in autoimmune conditions. So similar timeline. So what is one step that you could do today? One is to just roughly know whether or not you might be a candidate. You know, before you bring this to your doctor, it's reasonable to just do an honest internal assessment of where you are in your treatment journey. Do you have predominantly fatigue and pain? Or, have you been through hydroxychloroquine without meaningful relief? Do you have features of fibromyalgia or neuropathic symptoms? These are all really important questions to ask yourself and just to kind of think about. And you can write those down. Being specific with your rheumatologist or other clinician on your care team about why you're asking can be helpful. Rather than just saying, I read about LDN online, you could say, hey, I realize that my inflammatory markers may not be particularly high. I have a high symptom burden. I've been through other standard options, and I've heard that this may be helpful. What do you think? The second step is a little more practical. If you're going to have this conversation with your doctor or another clinician on your team, I would come prepared with 3 things just on a little sheet of paper and your notes just to have on your own. If you're wanting to perhaps use a compounding pharmacy, having some information on a compounding pharmacy in your area or a mail order that will send to you could be pretty helpful. It's also helpful to have a clear summary of what you've already tried, what has or has not worked, and to ask the question and frame it as an empiric trial with structured symptom tracking rather than an open-ended prescription. You could even ask like, hey, I'd love to try low-dose naltrexone for 8 to 12 weeks and track my fatigue and pain scores. I've heard from folks in the know and that are experts in this area that find it to be quite helpful. Sometimes that can help with that conversation, especially if you are working with someone who this is maybe a newer or brand new tool potentially to their toolbox. If you've been through the standard treatment options, done what your doctors have told you and still are not getting better, you're not failing treatment. The treatment is failing to catch up with what your body actually needs. The fact that there's no approved drugs yet that exist for Sjögren's and specifically Sjögren's fatigue is a system problem, not a personal one. It's conversations like this one about what the emerging evidence shows, what the mechanisms support, what you deserve to know. That is all a part of how this changes for the long term. So save this video for your next appointment, send it to someone in your life who's navigating the same thing and hasn't found language for it yet. And if you want to spend a weekend with clinicians and advocates and fellow patients and researchers who are all thinking about Sjögren's at this kind of depth, you should join us for the 5th annual virtual Sjögren's Summit. It's coming up in just a few weeks. Registration is now open. The link is in the description. It is free to attend live. And until next time, take care.